taking it, but nobody can afford shit. Okay, so today the first chapter we're gonna go over is pathophysiology. And then we'll go over the test. Did y'all bring the test?
Steven Seagal, yeah.
Yeah, Steven Seagal. See, if you can spend that amount of time in your Google machine to actually find out who that fat,
Because there's like this out there.
don't get pissed off, dude. It's the same way, the same over here. Couldn't remember his name because I don't think he was that important. I don't think he was that good of an actor. He could fight. I mean, I wouldn't fight him, you know, but I'm trying to clean my glasses, but my shirt's a little bit moist. So anyway, so we're gonna go over pathophysiology, and this basically all it is since we went over anatomy, that's the normal. It's supposed to be, this is the abnormals. So once we start dealing with the abnormals, we can find what diseases are. Is it a little more elaborate than the ECA version of it? Jeez. So let's see what happens. Okay, so basically, learning objectives. Okay, one of the key things, man. The hell I did with these. One of the key things is that oxygen, the reason we give oxygen to patients when you're dealing with situations that they're actually dying, like in a cardiac arrest or difficulty breathing, asthma attack, whatever, is because oxygen is one of the most important chemicals that we deal with because it deals with the function of the mitochondria through oxidative phosphorylation to actually be able to work. If you didn't have oxygen, it's like getting your car and putting a towel in your intake. It's not going to turn on. So the sugar's not going to burn, and you're not going to produce any energy, and your cells are going to die. And once they die, you get screwed. So basically, oxygen and glucose are necessary for normal cell function, and there's a process called oxidative phosphorylation. Oxidative phosphorylation, all it is oxygen and plus phosphorus, which is part of the Krebs cycle, and the way it actually functions to produce ATP as energy. And then I don't know if you remember your high school, you dealt with the Krebs cycle, which I never learned until I was in medical school. I took like 50,000 biology courses. Okay. But then in medical school, like, no, you need to know it. So I had to learn it. It's just a whole bunch of chemical processes that go through in the mitochondria that can actually cause energy production. So illnesses and injuries can actually disturb the delivery of oxygen and glucose and the removal of waste products. So once you mess around with that, then you mess around with the removal of waste products. And if you don't remove waste products, what's one of the most common waste products that our body produces? From cellular respirations, from anything. Carbon dioxide. You don't get rid of carbon dioxide, guess what happens? You retain it and you die. You don't die a little bit. You die about this much, you just die. It's like you're not a little bit pregnant, you're just pregnant. Okay. Illnesses and injuries can disturb this process. And the fundamental purpose of the emergency care is maintaining adequate delivery of oxygen and glucose. And there's this thing called the fixed principle. And I might have mentioned it last time, but the fixed principle, all it says is that in order for your cells to receive oxygen, you have to have an open airway. Okay. Before that, you need to actually be able to have what? Oxygen in the environment. So it has to be able to get in without no obstruction. So let's say if, for whatever reason you decided to go to Crazy Buffet and eat shrimp, and all of a sudden one gets stuck in your throat. Well, the fixed principle doesn't work because now oxygen can't get into your lungs. Not only that, it also states that within your body, you have to have blood to carry that oxygen from the lungs to the tissues. And within that blood, you have to have hemoglobin. Okay, and within the hemoglobin, you have to have iron for it to actually function and connect. If you don't have any one of those, the fixed principle doesn't work, so you die. Because I mean, I've dealt with patients where, oh man, he's having respiratory distress. So I give him oxygen. And I automatically put him on a pulse oximeter to figure out if this guy's actually responding to the treatment that I'm giving him. And I'm sitting down there, like the pulse oximeter keeps on going down. So I crank up the oxygen. Well, then I have to think about, well, why isn't oxygen getting to the cells in the finger where the pulse oximeter is connected at? So have to start thinking, well, is the airway obstructed? So no air is going in and out. I can hear the air going in and out in the lungs. So then maybe he doesn't have enough iron in his system. Or maybe he's bleeding internally where he doesn't have enough blood or red blood cells in his system. So you have to think about all those things in order to be able to get this guy to function correctly. Now, remember, you're getting paid minimum wage, so you can actually get this guy to live. So you're doing the job that he's not doing. You're doing it for him.
That's
Well,
why people that are like anemic when they stand up too fast, they get lightheaded because the oxygen is not being transferred properly.
yeah, well, anemia is one of them. Now, it doesn't have to be anemia. It could be just internal bleeding. I mean, I know that in one of the cases the case that I had that I got tested on when I was in medical school, they told me, oh, go to this room in hospital, I think it was the Easton. On the 7th floor, there's this patient, and the doctor was trying to be real cool with me because he liked me. I think he's got COPD. So okay, he's got COPD. So I went up there, thinking in my head, this guy's got COPD. And he had just been accepted to the hospital like 4 hours before that. Okay, so I went in there and I started listening to his lung sounds, doing a patient assessment. His lung sounds were clear. He had no wheezing, no nothing. And I don't know if you dealt with asthmatic patients, but you can give them medication. They're gonna have remnants of wheezing in certain part of the lungs, or somewhere in the lungs. Or if you have people that have bronchitis, you're gonna have a person that might actually have a little bit of gurgling, not gurgling, I'm sorry, bronchus. Or if you have a patient that might have emphysema, you might actually hear the bulla, which is that empty space of air that forms when the alveoli expands. So you go to lungs, I went like, okay, say the number 33, 33, 33, 33. And I kept on hearing, if I would have heard a clear 33 anywhere in the lung fields, that means that there's a pocket of air in there that's resonating the sound and I can hear it clearly. So he didn't have that either. So I decided to do a test that I remember reading about it when I was like in first year of medical school. I pulled down his eyelid, and his conjunctiva was white, completely white. That means that he's lacking blood because it should be pink. The other one you can do is have him stick out their tongue, and if it's white, that means that for whatever reason there's not enough blood going to the tongue, so they might actually have some type of anemia. So then I just asked her, decide to do a history on her. And one of the questions that I asked was, hey, when you go to the restroom, does it smell like Satan's socks? It's like, and she got like, her face just like lit up. And I knew that she had smelly poop. Okay, severely smelly poop. That when you crap, you flush right away before you even finish crapping because it smells really bad. And that's the thing. You never urinate before you poop. You always poop and then you urinate. So you can flush it right away. Or you can urinate before so you can flush it right away so you don't spend time so it can actually mix up and start coming out in the air so people will then find out that you actually pooped in their house. You have to do it really fast, dude. And lighting up a match.
The match is a great trick.
Yeah, but dude, if you're producing methane, you're gonna blow up. So, and normally we do produce methane with some issues. So I asked her, several questions, and I asked, hey, something, when you poop, have you ever looked at your poop? Is it very dark? What's the medical term for dark poop. Dark stool, what's it called? Right, I told you last year, I had a niece that her parents named her after dark poop. And she doesn't talk to me, hasn't talked to me ever since. Actually, if you ask me what she sounds like, I wouldn't know.
Man.
Close, close.
MELAN.
Milena. Her name is Milena, but it's actually Milena's dark poop, which has got blood already.
Yeah.
And when you have that, dude. Stupid little kid. Anyway, when you have that, your poop with blood tends to smell a lot. So, and eventually she actually had a GI bleed because she has melena. That means that she's bleeding internally and she's digesting that blood and it's going into her poop. So she had an esophageal, and then I found out that she had been taking medications for hypertension for about 20 years. Her liver's screwed up because you take medications for long periods of time, then your liver tends to get messed up and you develop cirrhosis of liver. It's not just for alcoholics, it's also for drug users and everything else. Okay, cellular metabolism is a process in which the body breaks down molecules of glucose and produces energy. And then how it breaks them down is by actually combining it with oxygen. Okay. Aerobic metabolism takes place when oxygen is available. When there's a lack of oxygen, you have anaerobic metabolism. And the thing with anaerobic metabolism, it produces less energy. Aerobic produces a lot more energy. So let's give it a number. With aerobic metabolism, when you have oxygen, you're going to produce 10 molecules of energy. But when you don't have it, when you don't have oxygen, you only produce 2. So your body starts deteriorating slowly until you die. So what's your job? Give them oxygen. The initial steps of cellular metabolism do not require oxygen, but produce only small amounts of energy. Oxygen is required to complete the process of extracting energy from the glucose and removing the waste produced by this process, which is carbon dioxide. Now, the other waste product that you have when it comes to cellular metabolism is water. So it's carbon dioxide and water. And when you combine those two, you develop carbonic acid. And carbonic acid is broken down into bicarbonate, which is a pH buffer. And you also, it's HCO3. HCO3. I forgot what that one is. It's carbonic acid, I think. So anyway, and it's an equation that you take a breath, it goes one way. You let go of air, it goes the other way. So it's constantly changing. So your body tends to go through the process. Now, that little thing right there, why you don't get to see it? Well, that thing right there is called the mitochondria. That's where all this occurs. That's where oxygen actually gets into there and glucose, and then it actually produces the ATP and the energy for ATP. Now, your job again is to produce oxygen. Now, let's say you give him all the oxygen in the world, but he doesn't have a heartbeat. You have to do CPR them. You have to CPR them. You have to give them chest compressions because if not, they're gonna die. Okay, the initial steps for cell metabolism take place in the cytosol, which is basically that cytosol is that fluid that's within the cell that holds all these little organelles. Okay, glycolysis produces a small amount of ATP, and that's when it's trying to get to the mitochondria. Then the process continues in the mitochondria, where large amounts of ATP are produced. And what's ATP? Yeah, adenosine triphosphate. Now, ATP goes through a process of losing a phosphorus, because A is adenosine triphosphate, 3 phosphorus to 1 adenosine. When, for whatever reason, you have oxygen, or the production of energy when you're using ATP, that ATP itself breaks down to ADP. So you lose one phosphorus. That's why oxidative phosphorylation the phosphorylation is part of phosphorus. So you lose and then you gain, you lose and you gain, and eventually you develop enough to where you can actually run every single cell. Now, every single cell in your body relies on this. So if a few of them die, that's okay. You still have 1 trillion more to go. But if enough of them die, then you start getting bad and bad and bad and bad. Okay, aerobic metabolism, the byproducts, heat, which is what's the normal temperature that we have?
97,
Nope,
98,
98.6.
so.
98.6, dude. That is the amount of energy that oxidative phosphorylation produces. That's why normal you have 98.6. Every single cell in your body is producing 98.6 as a temperature. Now, for whatever reason, if it goes up, it's because the body's either trying to rev itself up or it's got an infection. There's a couple of other situations, but once you start losing that temperature, that means your cells are not producing any energy or heat. So the other one would be carbon dioxide and water. Okay. The majority of ATP is used in the sodium potassium pump. You guys remember the sodium potassium pump? Sodium changes with potassium, and we kind of always study it when it comes to nerve cells, but it happens everywhere. In your stomach, when you have an unbalanced amount of sodium and potassium, you're gonna feel sick. You're gonna have diarrhea or you're gonna have constipation. Now, I think I remember I told you the story I had with a patient in Mexico. As soon as I told her, well, you're not gonna go ahead, and she had diarrhea, excessive diarrhea. So I know that part of it is because you have a sodium potassium imbalance. Okay, you might have too much sodium or too much potassium, so that's regulated. So I'll give you a little bit of Imodium. Imodium kind of calms it down and it regulates the sodium potassium pump. But as soon as I was about to tell her and writing down the script for finishing, I can't afford it. And I think, and in my mind, I'm thinking, oh, I guess you're gonna die. It's like, and I see, I was like, do you eat bananas? Yeah. Get a couple of bananas and take them. She comes in the next day. She brought the bananas with her. I can't. And I'm looking at her, it's like,
I remember the story now.
and I remember it. She was actually trying to put him in rectally. And I'm thinking, it's like, well, I told her, take the bananas. I didn't take them orally. I didn't write a prescription for bananas, right? So she is like, when I finally caught on, I was like, I was trying to hold it in. I was trying to write my report and I was shaking like this. Because man, I think it was my fault. I think, but you can't be that naive. Because I was ready to tell her, they make these little small bananas too. No, agarra la más grande, güey. La más grande. Dude, I don't make this shit up, dude. It's like this actually happened when I was over there. I know they got after me because I told a diabetic they couldn't control their sugar to cut down on beans because beans produces starch. It's produced, it's converted into starch. To give up rice because that is starch and tortillas. And the doctor's listening to this. They say, "Me la mataste?" But that's their meals. They can't afford meat. They can't afford anything else, so they go with rice, beans, and tortillas. So I told them, "Oh, cut it, córtale un poco." Of course, the doctors, in front of her told us, "Ya me la mataste. ¿Qué va a comer ahora?" Okay, the majority of ATP is used in the sodium potassium pump, which is usually regulates also a lot of things. And this is basically a fundamental picture of ATP and how it's actually required. And what happens is you have sodium as sodium potassium pump going in, and if you notice right here, okay, sodium has to be converted going from the outside to the inside and the inside to the outside. And that's sodium and potassium. Now, at this point, you only have sodium. And once it fills those three up, ATP is required for actually converting this organelle right there to open up on one side to release the sodium and allow the potassium in. So ATP becomes ADP because it lost the phosphorus. That phosphorus is an energy production. So eventually, what happens is the phosphorus connected there, it releases the sodium, and now it gets the potassium, so it can go back in. And the phosphorus is released once it happens, and it connects back to ATP. So it goes from ATP to ATP and back to ATP just because you lose the phosphorus. But if you didn't have that, if you didn't have any of that, what do you call it, oxygen or blood, that won't work. And your body starts malfunctioning and you start dying. There are pills out there that people take that actually mess around with this. Most of the people that have kidney issues, are hypertensive, take a medication that actually increases the speed of this in the kidneys, and they can actually lose a lot of potassium, or they can use a lot of sodium. Now, and I think I might have mentioned this, what is potassium used for? No, that's calcium. And that's phosphorus also, phosphorus is also producing. When you want to kill somebody, you take them to the electric chair. Well, not electric chair, one of the injections that they give you is pure potassium. And that causes your heart to actually contract and stay contracted, and it doesn't pump out. That's the whole process of actually killing somebody. Okay, byproducts of aerobic metabolism is heat, carbon dioxide, and water. Did I go the right way? Yeah. Okay, the majority of ATP is used by some potassium pump, and the pump fails, the cells will actually die. The first stage of metabolism is anaerobic. Remember, am I going the right way? Yeah.
Or it didn't repeat itself, but you already explained all this.
Yeah.
This in the slides.
Okay, so yeah, but because it's the same process. In aerobic metabolism, the combination of inadequate energy production and accumulation of lactic acid results in failure of the cell to process. So basically the same thing, the glucose broken down without the presence of oxygen produces pyruvic acid. Now, where do you get to see this? When you have excessive amounts of pyruvic acid. Now, you guys work out, right? No. If he, well, let's say you work out, but you tells, hey, let's go work out. And he sees you and you're working out like, and he gets jealous of you because you can lift up, all these weights and everything. So he wants to do the same thing. The only thing that the blood vessels in the muscles haven't spread out and developed that much. So a lot of the muscles are not receiving any oxygen. So pyruvic acid is formed in the muscles. That's where you develop soreness. And what's lactic acid? Pyruvic acid becomes lactic acid. Okay, so what happens is that the more you work, the more the blood vessels open up, so you can actually get oxygen to every single cell in the muscles. I'm more than sure you guys knew that, because I know that I started walking again because I had messed up my back in December, so like in March I started walking again, and I usually walk like 5 miles almost every afternoon. And dude, I couldn't even sit down from how sore I was. And that's just walking, not running. And I tell people, I don't go running, dude, because body parts are gonna fall off. I used to until I messed up my knee. It's like, hell no. It's okay. I can walk. I'll just walk faster. How much do you that way lift?
I don't like max out on it.
You just you're more revolution. I mean, not revolution. Repetitions and supposedly they tell me that's the best thing to do. But my son is about to walk and lift up 120 pounds without even sweat. It's like, I can ask you to lift them up. I don't have to lift them up myself. You want to live in this house? So he doesn't say shit. Okay, for perfusion, now you have heard of this word perfusion, right? Big, nasty word of perfusion basically means oxygen from the outside has to get to your cells. It has to go through the whole process So perfusion is basically oxygenation and the production of, the oxygenation of the cells and actually the getting rid of the waste products. So the deliver oxygen and glucose and other substances to actually the cells and elimination of waste products from the cells. It requires interaction of multiple components. So basically you have to have lungs. Okay, you basically have to, now if you're underwater and you start breathing, are you gonna get any oxygen? No. So you have to have an environment that has oxygen. You also have to have what? Cells that carry that oxygen. There can't be anything in the lungs that obstructs it. Like, so let's say you have a person with bronchitis or a person with asthma. They have constriction of the bronchioles, they can't get any oxygen in. So what do you do? What do you do when a patient has asthma? I know you want to give him, first of all, oxygen, right? But he's got asthma. You're gonna have a hard time getting that oxygen in. What else do? You said medication. Which one? You can't call it Atrovent. You can give him albuterol. You can give him well, there's a whole bunch of medications that it's different medications, but they're the same albuterol and Atrovent. Yeah, and all they do is they open up you can actually get.
I thought EMT scan. I thought it was only
No, you can give, dude, you can give it. Actually, ECAs, they're not supposed to, but I've seen a lot of ECAs. All you get is a nebulizer. You put it together, you put a few drops or the 5 mL of it connected to oxygen and have them breathe it in. That's all it is. It's not magic. So, and you guys, you get to do it. Or not, you actually get the metered dose inhaler, which basically you have to get something that is prescribed for that person. So if it's prescribed for that person.
That's what I thought, like if they already, asthma was like an underlying condition that they already had and they have to.
Yeah.
You can help them, but you're gonna help administer.
Yeah. But the problem is that sometimes they have a pump, but it doesn't have any more. So you need to give them albuterol. And for asthma, bronchitis, even some emphysema patients require that type of stuff. Bronchitis, you have mucus plugs production all over the place. With asthma, you have the bronchioles actually constricting, so that chemical basically causes a dilation. Remember when we went over anatomy, you have alpha 1, beta 1, alpha 2, beta 2. Those that medication actually activates one of those to actually open up, the one that causes bronchodilation. Okay, components. You have a composition of ambient air, which is the regular air that we have outside. Patency of the airway, so you have to have an open airway with no obstruction in there, right? Yeah, mechanisms of ventilation, basically, and by this we mean that you're able to breathe, that your lungs are expanding and contracting because your nervous system is actually causing your diaphragm to actually work and your intercostal muscles to work. This ventilation and perfusion ratio, and this is one of those where you have to have enough oxygen so it can actually go from a high concentration of oxygen to an area of low concentration of oxygen. And then you have to have high concentration of carbon dioxide to go the opposite way. And the transfer of O2 and CO2 in the blood and then to the target tissues, which is every single cell. Okay. You also have blood volume amount. You have to have enough blood in there. A pump that basically functioning, which is your heart. Systemic vascular resistance. Now, what does systemic vascular resistance mean to you?
the constriction of
Yeah.
your veins.
Well, think smaller. What's smaller than veins? What's smaller than what's the smallest type of blood vessel?
Capillary.
Capillaries, there you go. So systemic vascular resistance is the capillaries kind of close up, so you don't lose that blood and it goes back and it causes blood pressure. So you need to have blood pressure. Okay. Microcirculation also and blood pressure. Any alteration in the components may actually lead to poor cellular perfusion. and you have adequate perfusion, can shift cells from aerobic to anaerobic. And emergency care focuses on restoring and maintaining those components. So let's go over some of these. There's no oxygen in the environment. And it can happen. You can actually have someone that actually fell down carbon dioxide or carbon monoxide poisoning. What do? You take him out of that environment and you give him oxygen. Okay, high concentration, chingos of oxygen. Patency of the airway, and the airway is closed. What do? How do you open it up? Head tilt chin lift. How about if you suspect spinal injury?
Jaw thrust.
The modified jaw thrust maneuver. Let's say if you want to keep it open, but you don't have the time to maintain them like that, what do you put in there?
I don't know what it's called.
Oral, pharyngeal, airways. Those are you put in the mouth to keep it open. Now, if for whatever reason he has a gag reflex, you put the nasopharyngeal airway. Dude, EMS is simple. You just need to. And of course, there's no mechanics of ventilation. Let's say the airway is open, there's enough oxygen outside, but he's not breathing. What do? You get a BBM and blast him with positive pressure. Chingos of oxygen. Okay. If the heart's not working, then basically what do? CPR, right? If there's not enough blood volume, what do? Can you give blood?
No.
No. Well, what else can you do before that? Come on.
I just said rush to the hospital.
But how do you position the patient?
Shock position.
Shock position. And what is that state? That you elevate the legs, but at the level of the hips. So the legs are elevated, but the hips are flat. You can put them in the hospitals whenever you get to see them working on a cardiac arrest patient, they completely tilt them head down like this. So that's a Trendelenburg's. And no, I can't say that. I'll say it afterwards because I'm being recorded. So composition of ambient air. You have 21% of oxygen in ambient air. Whatever we're breathing right now is 21%. So I'm telling you this because this isn't in the book. But I'm also telling you this because if you run out of oxygen, I don't have any more oxygen, I'm not going to ventilate them. You dude, just don't apply oxygen to the BBM, you're still giving him 21%. 21% is a lot better than 0. Of course, 100% is a lot better than 21%. But if you say, something, I'm going to give him mouth to mouth. 16, 17%. So which is better? 21%, right? No matter how pretty she is. Or he is nowadays. So basically, this is what you find in ambient air. About 21% of oxygen, nitrogen is 78.8, argon is 0.93, and carbon dioxide is 0.03. Okay, composition of ambient air, FiCO2, which is, I forgot what that stands for, is the inspired, I'll remember just a little bit. Is the fraction of inspired oxygen. So that's the amount of oxygen that's actually going into your system. The FiO2 is a fraction of delivered oxygen. One way to improve cellular oxygenation is to provide supplemental oxygen. And you guys carry oxygen, right?
Yeah.
Both in-house and transportable, okay? Portables. Patency of the airway. A patient's airway is open and not obstructed by any substance like the tongue, fajita. The only way I remember fajitas is because I remember I received a call while I was at La Siberia restaurant and I ordered fajitas. So I received a call and it was one of my subordinates, one of the teachers that I had working under me. And he just started complaining. Man, I got that piece of fajita about this big stuck right there. So I started coughing and I couldn't get it out. So I got up and went to the restroom. Like what they tell you that people do, they actually do it because I did it myself. That's called a cafe coronary. And I was in there trying to grasp that piece of thing. So I was like, oh, I'm gonna go ahead and do. And not only that, I had the phone there and I could hear the guy just yapping and yapping and yapping. So as soon as I got that piece of meat out, I didn't chew it correctly. I just flushed it down the toilet. I did this to the phone and hung it up. Establishing an open airway is the first steps in actually emergency care. Failure to establish and maintain a patent airway leads to cellular hypoxia, and hypoxia leads to cellular death. Remember, cellular hypoxia can be reversed. Cellular death is not reversed. So let's see if you have a person that's actually not able to breathe. Within the 6 minutes or 10 minutes that you find them, you can actually reverse whatever damage that's actually happened. In the paramedic level, I usually tell the students, you know, when we're looking at the electrocardiogram and you're seeing an ST elevation, that means hypoxia. And if you're not sure if it's hypoxia or cellular death, give them oxygen. If it doesn't change, they are going through a myocardial infarction, heart attack. But if it changes, they were just hypoxic. Okay, locations of area obstructions, it could actually happen in the nasopharynx. But if it happens in the nasopharynx, guys, you can still breathe through your mouth. I know a lot of people that are mouth breathers. Okay. The oropharynx, the epiglottis. Now, and the epiglottis could be because of a disease, or it might actually close up, it might actually get inflamed, whatever. The larynx, the same thing. Trachea, we've actually gone all the way down to the trachea and closed it. Bronchia or bronchioles, which are either could be a foreign object or it can actually be constriction or mucus that actually has been produced and clogging it up. So basically, that's a picture of everything that we just talked about. Okay, it just depends on where you're going to find it. An intact thoracic cavity is integral for normal ventilation. So what does that mean? An intact thoracic cavity. No broken ribs, no stab wounds to the chest. If you have a stab wound to the chest, the lung is going to collapse. Okay. Now we have Boyle's law defines and illustrates how ventilation occurs in the body. Now Boyle's law is part of physics. Well, I remember I studied in chemistry. Yeah, basically, if you lower it, it's gonna equalize, and because of everything tends to equalize, and that's the same thing in the body. You know, if there's a lot of oxygen outside, and you don't have enough oxygen inside, you're gonna no matter what, something's gonna happen that's gonna equalize the amount of oxygen inside the lungs and outside the lungs. Yeah. There's pleural lining, which basically, remember, what does the visceral lining cover?
What is it covered in?
No, what does it cover? Because remember, we have two linings. One's called the visceral pleura and the other one's called a parietal pleura. The parietal pleura covers the cavity itself. Let's say if you were talking about the lungs, it covers the, what do you call it? The lung, the ribs, and you know, the outer portion of it. And the visceral means organ. That covers the organ itself. And in between those two, there's a little bit of fluid that causes it to actually well, it keeps the pressure, keeps the lungs expanded, but it also causes lubrication. I know because I got freaked out. I had gotten a stethoscope, an expensive stethoscope, the black edition. Okay, so I had gotten that one, and then my dad had given me one, which is basically another one, but it was a different one. It was a Littman. And when I was listening to the lungs, I wasn't lifting it up. So I was just running it across. So in my mind, I heard a pleural rub. And the pleural rub is whenever you have an infection causing inflammation. And I told the doctor, I think this guy has a pleural rub. And he looks at me like, typical doctor. ¿Me quieres matar al paciente? And I'm thinking like, well, I heard pleural rubs again. Listen again. So I listen again. Okay, next time now, lift up the stethoscope and put it over here. Because what you're rubbing is you're listening to the stethoscope running against the shirt. And if the guy had a plural rub, he would have been screaming in pain every time he took a breath.
That's some like the. It's running without lubrication.
It's without lubrication and including inflammation. I remember, I mean, you heard heart sounds, right? Dub dub, dub dub, dub dub. I remember this little girl, I was listening to her heart, and it was at the clinic, one of the clinics in Mexico. And I heard this. And now the first thing that came to me was like, "Ah, chingo, what the hell?" And I look, when I pulled down the stethoscope, the little girl had actually had heart surgery. So she had an infection in the pericardium. So I was like, oh. So, I didn't have a medication to give her. I could have given it to her, but I can't trust them to go to the pharmacy and get it. So I made a referral to the emergency room so they can actually treat her there, and then eventually give her something for an antibiotic or something. So any damage to one of these things can actually disrupt normal ventilations. Now, question, check the event that actually occurs just prior to the movement of air into the lungs on inhalation. Does the diaphragm relax? Does the size of the chest cavity decrease? The pressure within the chest decreases, or the intercostal muscles relax?
Basically using movement and.
Well, does the diaphragm relax? Okay, it does, but not when you're inhaling air. When you're inhaling air, it straightens out, so it's contracting. So the lungs can actually get air in. Okay, so that's not it. The size of the chest cavity decreases. No, it actually increases, right? The pressure within the chest decreases.
Yeah.
Yeah, because if there's less pressure here, it's gonna force air from the outside to come inside to equal itself out. So that's the answer. Okay, mechanics of ventilation, accessory muscles used in extra effort is needed for inhalation or exhalation. Indications of heightened ventilatory effort and requires more energy. I know it's if you have some type of obstruction or maybe an asthma attack or whatever, your body's gonna require more energy to actually cause these muscles to contract and relax. Actually, sometimes forcibly relaxing to get air out. Accessory muscles, we have three different ones. You have the sternocleidomastoid muscle, which is the one that runs from right here, and right here, causing the sternum to actually barrel out. We have the scalene muscles, elevates ribs 1 and 2 right here. So the scalene muscle actually causes air to be forced in, and the pectoralis major, which is your major chest muscle. And these are accessory muscles. Now, notice I didn't mention the diaphragm. The following accessory muscles of exhalation are used to actually decrease the size of the thoracic cavity and to create a more positive pressure, forcing air to be outside, because now the pressure inside is higher than outside, so it's trying to equalize out. So abdominal muscles and intercostal muscles are the ones that I use. The intercostals are the ones between the ribs themselves. The abdominals are going to be the what? The abs, yeah. I heard calves. We can, but I don't know how it's gonna work. Okay, airway compliance and resistance. High resistance and low compliance increases the effort needed to actually breathe and lead to hypoxia. A compliance disorders make it hard to actually for the lung tissues to inflate. In resistant disorders results from a constriction of small airways. So basically, you're not getting air all the way in. And remember, the only part of the lung you're gonna have carbon dioxide and oxygen exchange is gonna be in your alveoli. If for whatever reasons the tubes that go to the alveoli are clogged up with mucus, you're not gonna get anything. And if you lose that elasticity of the alveoli, which is which disease? There's three diseases with COPD: asthma, bronchitis, and emphysema. Nope. Emphysema. That's when, remember I told you about the underwear, your favorite underwear, and they use the elasticity? The same thing happens to the lungs. Now, the way you can actually find out,
No bronchitis?
bronchitis produces mucus.
Yeah.
And that clogs up the air. Now, bronchitis leads to emphysema in the long term. So if you have bronchitis, air might be getting in, but it's not able to get out, so that alveoli starts expanding, and eventually it loses the elasticity. There's specific cells in the system that actually cause it to. What's this girl looking at? Makeup tutorials?
It's hot.
I know. You can open up the air a little bit. I mean,
Oh, wait.
the door.
It's like a break of it.
There's no breaks, dude.
No breaks.
You're the EMT basic level.
That's usually-
What gas station? There's no gas stations. Hey, dude, open the door. Hey, dude, open the door. But the whole library is,
Yeah.
Probably lost these skills. We were at Edinburgh Children yesterday and they had a fire, so like, what do you see?
damn. Okay, pleural space, negative pressure is maintained in the pleural space. Cavity, an injury to the chest wall, like in a stab wound or broken ribs that are open, can actually cause this, and the lungs may actually collapse from air accumulation in the cavity itself, not in the lungs, but in the cavity. Okay, now key thing about this, minute volume, the amount of air moved in and out of the lungs in 1 minute. Memorization, minute volume, the amount of air that's actually moved in and out. Now, minute volume equals tidal volume plus frequency of ventilations. To ensure adequate ventilations, both the tidal volume and the respiratory rate must be adequate. So what is the minimum number that you deal with when you're dealing with respirations? How many respirations would be the minimum? You can go a little bit, 12 to 20, so 12 would be the minimum, right? So if it goes below 12, you have to work to ventilate this patient. If it goes above 24, you have to work to maintain ventilation, because fast respiration doesn't cause oxygen to go in and out.
Fast respiration with
Hyperventilation,
you get too much oxygen in your body.
yeah, but there's no exchange of carbon dioxide and oxygen because it doesn't. If you breathe real fast, when was the last time you guys took your CPR class?
Before we did the EMO.
I did it online.
Okay, so basically what I'm trying to say is that the key thing that they're telling you now is that you have to have strong ventilations. You have to use a BVM, and actually not fast, but strong, and works with force. Because you're trying to get that oxygen that's inside the BVM into the alveoli. If you do it real fast, it might not get all the way to the alveoli. So key thing is, if they're panting, like they're having a hyperventilation syndrome, then or a panic attack, they're not getting any oxygen. I mean, they're not getting rid of the carbon dioxide because it's not going in there to exchange. Alveolar ventilation, the amount of air moved in and out of the alveoli in 1 minute. Dead space is whatever is there to leave the lungs open. So if you want to blow all the air out, you can actually forcefully try to do it. So you take a deep breath and then you blow out air, and then you blow out more air, and then you blow out more air. But there's a compliance in there. There's amount of oxygen in there that will actually keep the lungs open. Now, if somebody sucker punches you, then you get into a process called atelectasis. So now everything is closed up and you're not getting any oxygen. So you have an average of 350 to 500 mL of tidal volume reaches the alveoli. So that's about how much oxygen you actually get. Hypoxia can occur from low tidal volume, a slow ventilatory rate, or a fast ventilatory rate. A typical pulmonary illness and trauma affect the tidal volume more significantly. So if you have any type of trauma, yeah, or yeah, like what they call paradoxical movement, when you have broken ribs, then you get affected. Okay, breathing is an involuntary process controlled by the autonomic nervous system. So you don't have to think about breathing, it happens automatically. You don't have to think, oh yeah, I forgot to take a breath. Now, you can hold your breath, which is kind of voluntary, but eventually once you pass out, I told you about my friend, right? He's a border patrol agent now. When we were in high school, we would play, they would be playing this game that would stay, let's see who can hold our breaths the longest, right? Of course, all of us, and he wanted to join in, so all of us like, okay, but dude, you can hear that. So we're pretending to hold our breath, but we're breathing through our mouth. This guy didn't. Dude, I just saw this guy turning pale, and he just rolled his eyes back, and boom, you hear the clonk when his head hit the floor. What did we do? Like cucarachos, when you turn on a light. Like, ay, madres, he's possessed, he's possessed. Of course, we were back before EMS, so. Receptors, okay, breathing is involuntary. You have receptors, measure the oxygen and carbon dioxide levels and hydrogen ions. So basically, they check to see how much oxygen, how much carbon dioxide, and the pH of your system. So you have pH receptors, and you have the other one's baroreceptors. Okay, the receptors send signals to the brain to actually adjust the rate and depth of respirations. So we have little mechanisms in there, like your car has a little sensors to find out how hot it is, how much oxygen there is, how much carbon monoxide is leaving the car, and whatsoever. So chemoreceptors, yeah, central chemoreceptors, and you have peripheral chemoreceptors. So we have hypercapnic drive and you have the hypoxic drive, and these drives are the ones that actually cause you to actually breathe. So the more carbon dioxide in your system, the more you want to breathe. That's what triggers it, not the amount of oxygen, but the amount of carbon dioxide. And that's basically hypoxic drive is low oxygen, right? So you have low oxygen, you have high carbon dioxide, which is hypercapnic. Okay, so ideally, if for whatever reason you hold your breath, you put a plastic bag on somebody's head, they're gonna want to breathe a lot faster because their hypercapnic and hypoxic drive kick in. But in emphysema patients, it becomes so common that the body is something. Let's see if we try it this other way. Instead of checking for carbon dioxide, we'll check for the amount of oxygen. So what happens is that lack of oxygen will cause you to breathe. So that's why they tell you when you have a patient that is going through has an emphysema patient, do not give him that much oxygen because you're going to slow down his respirations. The more oxygen, it lowers it. What?
Nasal cannula too.
Nasal cannula at 2 to 6 liters per minute. Now I know that I was yelled at one time, and because I mean I understand the process where, yeah, an emphysema patient does not require that much oxygen because they're going to stop breathing. But what do? Yeah, you tell them, take a breath. Or hit him on the back of the, every time I touch you in the back, I want you to force him to take a breath because it's voluntarily controlled. No, hombre, me dio una pedorreada in the ER. Again. And I told him, sir, this guy was cyanotic. I know he's an asthma patient. I mean, an emphysema patient, but this guy was cyanotic and he's a cancer patient. I gave him 12 liters per minute because he was hypoxic. And it was before we actually carried the oxygen, the pulse oxygen was on. So I told him, well, he doesn't look cyanotic now. Because the treatment that I gave him worked. And he just, the nurse was there and the nurse could figure out what I was saying. And the doctor just like, well, next time, just be careful. And I'm thinking like, so no matter what, you're going to be right and I'm going to be wrong. So fine. Then I walk outside and the nurse tells me, hey, Bart, I remember her name was Bart, I don't know if she died. came up to me and told me, hey, can you tell this guy in the taco truck that I want a certain amount of tacos and whatever. So I was like, you want me to go ahead and translate for you because you can't talk Spanish? Like, yeah, please. And I think he's like, and I'm thinking, weren't you just the one that tried to get me into trouble? So I went out there and I told the guy something sexual that she wanted to do to him. And it involved something. So, um, he was like, ¿Qué? So anyway, COPD patients have a tendency of retaining CO2. They become insensitive to the small amount changes of CO2, and the respirations are controlled by decreased oxygen levels. So you lower the oxygen level, then they can actually breathe. But if you give them too much, they stop breathing. That's what we call a hypoxic drive. Okay, and these are receptors that you're gonna find inside your body that will actually send the signals to the brain to actually cause you to breathe faster or breathe slower. You have 3 different types of receptors within the lung that provides impulses to actually help regulate respirations. You have the irritant receptors, stretch receptors, and the J receptors. Now, I actually encountered the J receptor once. And the J receptor usually kicks in when you have somebody that's their lungs are filling up with fluid because they're going through pulmonary edema. And once it gets to a certain level, they just boom, they start breathing fast. And they can't they can't slow it down. They're just breathing fast and fast and fast and fast. And I know in the ER what they did is they were trying to give him some Lasix, but that was going to be taking a little bit too long for him to. He was going into cardiac arrest, so we actually put a tube down the mouth and sucked out some of the fluid inside not the mouth, the lungs, and sucked out some of the fluid inside the lungs. Kind of helped him, but didn't slow it down. But eventually, and I remember we wanted to transport him, and I told the doctor, I'd love to transport him so he can get better care. He's not stable. He's gonna die on me on the way to the hospital. So let's stabilize him first, and then we'll go and transfer. And the nurse said, I agree. And I'm thinking, nobody asked you. I agree. The stretch receptors is you can only take, you can only breathe in so much. Yeah, breathe in so much before your brain tells you stop. So, of course, the irritant receptors are the ones that actually are caused by irritants that, if there's an irritant that gets into your lungs, you're going to try to breathe a lot faster. The regulatory centers is the brainstem. Yeah, the ventral respiratory group, the dorsal ventilatory group, and the pontine respiratory center. Okay. Ventilation perfusion ratio. This is what we have to worry about. How much oxygen we're giving, and not only how much oxygen, but how much oxygen is going to leave going in and how much carbon dioxide is going to exchange. So the ventilation perfusion, also known as VQ, is the relationship between alveolar ventilation and perfusion of the alveolar capillaries. The relationship influences gas exchange and can actually be used to explain causes of hypoxia. So an overview of ventilation perfusion, you get some in the lungs themselves, and in the heart and in the tissues. Okay, so basically all it is by the process of diffusion, molecules are going to go, or substances are going to go from an area of high concentration to an area of low concentration. So it's going to go from an area of high concentration that's outside of the body to an area of low concentration, which is inside of the body. And when it comes time to in the capillaries and the tissues, where carbon dioxide is high in the, it's very high in the tissues themselves because they're going through a metabolic process or anaerobic metabolism and oxidative phosphorylation, right? So all these things are happening. So the byproduct or the waste product is going to be CO2. So it's staying there. Now, blood vessels have to be close to that area and cause the red blood cells that are rich in oxygen to exchange with carbon dioxide. So rich in oxygen will go to the tissues because there's not enough oxygen in there, and the carbon dioxide will go to the blood because there's too much carbon dioxide in the tissues. Ventilation perfusion, in an ideal state, the amount of ventilation is usually match to the amount of perfusion. However, a perfect match does not actually occur. Overall perfusion exceeds ventilation, but the situation is highly functional. When ventilation is better than perfusion, there is wasted ventilation. So when you breathe too much, you're wasting your ventilations. Okay, when perfusion is better than ventilation, there is wasted perfusion. When there's too much oxygen, it's actually transferring itself to where it's supposed to go, then you waste perfusion, which is not bad. Okay, and that's another representation of possible causes of ventilation disturbances. Basically, deal with, if you notice the one over here, that's an obstructed airway. So you're not gonna get enough oxygen to the alveoli to oxygenate it. And you, yeah, this one is an airway obstruction disease, the trachea, and this one is what? A blood vessel that's actually obstructed, causing oxygen not to get into the bloodstream. That's a pulmonary embolism. Pulmonary embolism, also known as PE. Pressure imbalance. If the air pressure in an alveolus exceeds the blood pressure in the capillary bed, blood flow through the capillary stops. It occurs normally in the apex of the lungs. What is the apex of the lungs? Apex, if you want to remember what apex is the pointy level of the lungs. So where's the pointy level? At the bottom or the very top? The top, right? So it usually occurs there. It occurs when the systemic blood pressure decreases. So when it decreases, there's not enough oxygen, blood going to the lungs, and there's loss of perfusion in that area. Okay, ventilator disturbance is a condition that decreases the amount of air reaching the alveoli, such as asthma, results in wasted perfusion. So hypoxemia and hypoxia result. And you want to remember hypoxemia and hypoxia. Hypoxia is the big word. Hypoxemia happens because of hypoxia. Okay. Treatment is aimed at increasing lung ventilations. Perfusion disturbances also, if you have ventilation that is normal or even decreased or increased, I'm sorry, but blood flow through the lungs is decreased. There is wasted ventilation leading to hypoxemia or hypoxia. Administering oxygen will actually help, but the perfusion disturbances must be corrected. So you need to fix whatever might be wrong with the patient. Oxygen will actually be continuously delivered by the blood of the cells, carbon dioxide and CO2 and CO2 by blood. Transfer CO2 and CO2 by blood. O2, I'm sorry, I keep on seeing CO2. Okay, so oxygen must be continuously delivered to the blood, by the blood to the cells. Carbon dioxide must be carried back to the lungs to be blown off in exhalation. And the disturbance in transport system may actually lead to severe hypoxia and hypocarbia. So basically, O2 has to go from the lungs to the tissues, to the blood, and then from the blood to the tissues. So O2 is transported in the blood in two different ways. 1.5 to 3% in dissolved plasma. So plasma actually carries oxygen. 97 to 98.5% in attached hemoglobin molecules. Role of hemoglobin is a protein molecule that contains iron, and there is 4 iron sites per hemoglobin. Now, how many hemoglobin molecules do we have in a red blood cell? Lots of them.
What was the question? Sorry.
How many hemoglobin molecules do we have in a red blood cell?
How many molecules do we have in our blood cells?
Yeah. How many hemoglobin? We have a lot of them. Now, the key thing is that, but there's only 4 iron molecules per hemoglobin molecule. So your cells can carry a lot of oxygen and carbon dioxide. Now, carbon dioxide is transported in the blood in three different ways. 7% in dissolved plasma, 23% is attached to the hemoglobin molecule, and 70% is transported by the lungs in form of bicarbonate. So once we start getting into more advanced levels, we start studying how the pH actually affects, or how to actually regulate pH in the body, and how it actually affects how you actually breathe and how you actually ventilate yourself. And one of the things that, the first one is going to be the bicarbonate system. And that's a quick exchange of carbonic acid to bicarbonate. The other one would be the respiratory system, which you breathe in, you change the pH of your system. Because oxygen causes alkalosis, while carbon dioxide causes acidosis. The third way would be your kidneys. The kidneys have long-term effects on controlling pH. And how do they do it? By urinating acids, molecules and acids that are combined within you're gonna get uric acid that has oxygen and carbon dioxide and carbons in them. And then there's a chemical process that actually combines all that, forming uric acid, so you can actually control your pH. Now, if you have a problem with your kidneys, you're screwed. That's why they go through dialysis, because they can't get rid of the uric acid. So, attached to hemoglobin and dissolved in plasma. Carbon dioxide is transported in the blood three different ways, which is bicarbonate, attached to hemoglobin, and dissolved in plasma. Yeah, alveolar capillary gets gas exchange after inhalation. The alveolar air is high in O2 and low in CO2. Then you have venous blood, that capillaries surrounding the alveoli is low in O2 and high in CO2. So it tries to equals itself out. It doesn't try, it does it. So click on the mechanism in which the most of the oxygen in blood is transported, bound to hemoglobin. It's a form, yeah, it's letter A. It's like what, 97%? Okay, blood volume. The determinant of blood volume pressure is perfusion is blood volume. Adults have about 70 mLs of blood per kilogram of body weight. So you have 70 kilograms. A 70 kilogram adult will have has a 4,900 mLs, or 4.9 liters of blood. So ideally, what you do is you have to have a certain amount of fluid in your system within an enclosed system. Or you cannot have a blood vessel bleeding out, because then that means you're losing blood. Blood volume, blood composition is 45%. It's formed elements, and the formed elements are white blood cells, red blood cells, platelets, and 55% is plasma. Okay. So that's when, if you've ever taken anatomy or a biology class, whenever they draw blood, they leave it standing for about an hour. You're going to have the separation of plasma and the formed elements, and that's what it means. The formed elements are red blood cells, white blood cells, and the platelets. While plasma is the fluid portion of the blood. Blood distribution, the majority of the blood is in the venous system. The majority of the blood, a minority of the blood is in the arterial system. 64% in venous, arterial. It's 13. Excuse me. You have pulmonary vessels 9%, capillary 7%, and the heart is 7%. Blood volume, hydrostatic pressure. Now, this is if you have a high amount of blood pressure in your system, and it forces the walls to be stretched out, causing the fluid to leak out into the interstitial space. So think about a blood vessel being this tight. and it kind of separates, and it leaves a whole bunch of open spaces where fluid now can actually go. That's why, you have, patients that have kidney problems, they're swollen up. Shit. Someone-
+1-800-292-7508.
Because no one is-
But that's a great, alarm in there.
and, on Sundays, you can't find it because when I go to church, so I'm scared to go to hell. I lower the volume and I forget to turn it back on. And people are calling me, like, I tried calling you. Yeah, lower the volume. So anyway, hydrostatic pressure is that pressure that's being put against the blood vessel that causes it to leak out. From the inside of the vessel, or capillary bed generates by contraction of the heart and the blood pressure. Hydrostatic pressure exerts a push inside the vessel and the capillary. So what does this mean? It keeps fluid inside the blood vessels. Now, plasma oncotic pressure. Now, plasma oncotic pressure, you have to think of plasma being a molecule, okay? And we have, well, not plasma, but the chemicals in plasma. We have albumin and all these chemicals that are very big, okay? And what happens, have you ever heard of the term, when you were in high school, oh, I'm gonna give you a salt pill so you can retain water so you don't dehydrate? Well, they give you that so the salt content in your blood is higher, so it sucks out all the water from the surrounding tissues. Okay, same thing with this. Albumin is a very high molecule, which basically causes the water from the interstitial fluids to come back into the blood vessel, giving you blood pressure. Now, if for whatever reason this is oncotic pressure, if you have the hydrostatic pressure, it's too much and it cannot retain it inside the blood vessel, so you start losing fluid. You might take the blood pressure of the patient and, oh, why is it so low? He looks okay, but he's swollen up because the plasma is not inside the blood vessel, it's outside the blood vessels. They tend to lose blood pressure. Large plasma proteins have an effect of pulling water into the capillaries. So that's what, if you see the first one about H2O leaving the body, you have hydrostatic pressure because the pressure is very high. Then you have the oncotic pressure sucking the blood back into it. Okay, pump function of the myocardium. The myocardium must be effective pump to actually maintain a perfusion. Cardiac output is the amount of blood that's actually ejected from the heart in 1 minute. So cardiac output equals to heart rate and stroke volume. And stroke volume is the amount of blood that goes in one pump. Okay. So the pump function in the myocardium must be an effective pump to actually maintain perfusion. You have heart rates, basically it's controlled by the sympathetic and the parasympathetic. Guess what the sympathetic system does? Does it increase the heart rate or it decreases it? Increases it. The parasympathetic decreases it. Okay. The myocardium must be effective pump to actually maintain perfusion. Stroke volume. We start talking about preload, contractility, and afterload. So imagine you have the heart. Okay. Whatever blood's coming from the vena cavas, that would be preload. Whatever blood is actually being pushed out to contraction is afterload. So why am I telling you this? Well, if you have to think about it, if the amount of blood that's going into the atriums to the vena cavas is low, then your afterload is going to be low. Now, if the preload is high, that means that the heart's going to have a hard time trying to contract, push that blood out, because there's going to be a very high pressure there because it's maintaining. I mean, that's why hypertensive patients get an enlarged heart. We're talking like Biden, right? Man, the thing,
It's gonna fall over.
dude, there was no sandbag there. Why would there be a sandbag? Come on. the FBI is gonna come and search for us. So basically, that's what it means, you know, if you have a good preload, you have a normal amount of fluid coming in, if you have a low amount of preload, then the afterload is gonna be less. So what? Okay, factors that increase cardiac output. And what causes the blood pressure to get higher and whatsoever. So you have increase in heart rate. So if your heart rate goes up, your blood pressure is gonna go up.
Yeah.
If you have increase in blood volume, if I forget to shut down that IV and overfill you with fluid, your blood pressure is gonna go up. Okay, increase in myocardial contraction. So if I scare you and your sympathetic system releases epinephrine, your heart contraction is gonna be that high. That's gonna increase the heart blood pressure. Okay. So the sympathetic stimulation, also the beta 1 stimulation from epinephrine, which is by adrenaline, and the lower diastolic blood pressure. Now remember, the blood pressure is broken down into systolic and diastolic. Which is the top number?
Repeat that.
Blood pressure is divided into systolic and diastolic, like 120/80. What's 120? Systolic or diastolic?
This start. The first one.
Systolic. Systolic, yeah, you're right. And the way I remember it, well, the top number goes with the last part of the alphabet, which is S. I mean, that helped me. Factors that decrease cardiac output, you have decrease in heart rate, decrease in blood volume, decrease in myocardial contractility, parasympathetic stimulation, and the previous one was sympathetic, this is parasympathetic. Beta 1 blockade, beta blockers, and higher diastolic blood pressure. So you start thinking, well, what is diastolic and systolic? And the first one, it was lower diastolic blood pressure. So remember, when we're dealing with this type of situation, the amount of blood, and I drew this previously, I don't know if you guys remember. So let's see if we have a blood gulp right there. Your ventricles contract and they develop that. And you have the blood vessel right there. The amount of pressure that's being put against the blood vessel is your systolic. And the amount that is left behind is your diastolic. So in this one, it tells you the higher the diastolic blood pressure, in other words, if this one's actually contracted a lot smaller.
I just realized we can't see what you're drawing.
Oh,
I was like, why is he talking so slowly?
I can see it right there. It'll probably show up in the presentation. So you have to watch these, so you can give me points in YouTube. Basically, it's telling you that the amount of the higher the diastolic, the harder it is for actually to contract. So let's skip this. I didn't realize I'm looking at the damn computer. So blood vessels can actually cause become vasoconstricted, normal or vasodilated. When you have an increase in vasoconstriction, you have a decrease in blood vessel size, and increases systemic gravity resistance, which causes you to have high blood pressure. A lot of the situations when you have a person that's actually given medication to actually work with blood pressure is to dilate those blood vessels. We'll call the ACE inhibitors. Of course, when for whatever reason you take a medication that causes vasodilation, your blood pressure actually goes down. Okay, pulse pressure is the difference between the systolic and the diastolic blood pressure. And that's the difference between, so let's say you have 120/80, what's the difference between 120 and 80? 40, right?
No.
30. 80.
Oh, 80. I thought I did it.
So you have pulse pressure of 40. Okay. Okay, microcirculation refers to flow of blood through the arterioles, capillaries, and venules, which are small. Now, this here, what you see in the capillaries, if they completely shut down, they increase your blood pressure. Because now you don't have wasted whatsoever and everything is backing up. So regulatory influences on sphincters. You have local factors, neural factors, and hormonal factors. Okay, the sphincters are the muscles that are surrounding the blood vessels themselves, specifically the capillaries. So blood pressure equals cardiac output plus systemic vascular resistance. So relationship is systemic vascular and the heart rate and cardiac output. You have an increase in SV's systemic vascular increases CO or cardiac output. A decrease in SV also decreases cardiac output. An increase in heart rate increases cardiac output, and decrease in heart rate actually decreases cardiac output. So it's the same thing, we're just renaming it at this point. So blood pressure. The general effect of blood pressure is the perfusion. And the perfusion is increased blood pressure increases cellular perfusion. Decreased blood pressure decreases cellular perfusion. So our main thing is not only to give them oxygen to maintain blood pressure also. And then when you took a CPR class, the magic number that they gave you was 10. So you cannot stop ventilating or doing compressions for more, not ventilation, but for more than 10 seconds. Because the blood pressure will drop. Okay, regulation of blood pressure by baroreceptors. Baroreceptors are located in the aortic arch and actually carotid sinuses detect changes in blood pressure. Signals are sent to the vasomotor and cardiopulmonary centers in the brain. Okay, so basically they regulate, they sense how much pressure there is in there. And if the pressure is low, it's gonna cause the heart rate to go faster and cause vasoconstriction. And you can see this when you lie down on the floor and you check your pulse, and then you get up real fast and you check your pulse increases. What you don't get to see is your vasoconstriction also is caused. Regulatory blood pressure, regulation of blood pressure by chemoreceptors. A decrease in blood pressure oxygen level stimulates the sympathetic nervous system. And the heart rate increases the blood pressure of the blood vessels, constrict the hypoxic and actually present with pale, cool, clammy skin and increased heart rate, which is basically your regulatory mechanism to actually maintain blood pressure. Components of aerobic metabolism. Oxygen components, ambient air, patency. Now this is going over some of the stuff that we want to. You have minute ventilation, ventilatory rate, and tidal volume, and alveolar ventilation, which is ventilatory rate and tidal volume. Perfusion in the pulmonary capillaries, you have venous volume, right ventricular pump function, or it's the right side, because that's the one that actually sends it to the lungs. Gas exchange between the capillaries and the alveoli. You have the content of blood, you have red blood cells and hemoglobin and plasma. cardiac output and determinants, heart rate, preload, stroke volume, myocardial contractility, and afterload. Systemic vascular resistance, you have sympathetic nervous system stimulation and parasympathetic nervous system stimulation. Gas exchange between the capillaries and the cells also occurs. So at this point, I want to go ahead and kick us out of this. I have no clue.
I
You
think
say
that-
so.
I think we should go and see.
Let me sit up there.
Honestly, there might be a restaurant right there behind.
There's restrooms, I know that much. Maybe they're on the outside of the library. They might be in the outside of the library. Be careful with the wire.
Got your laptop or what's in?
Of course, the other one's too
Another
that.
gaming laptop?
Hey, you can't go wrong with Alienware, do you?
Yeah.
No, don't think it's new.
The VC going off inside of the library.
It's what?
As soon as you walk out the doors that we see working.
Well, I mean. I don't know. I mean, we're not producing that much heat, but when I walked in, I noticed that it was very hot. And it feels humid.
Yeah.
It's cold in the hallway, I don't know why it's not cold in the library.
Oh, outside the library, it's, yeah,
Outside, like in the main, it's cold, it's hot in here.
oh, it's probably because of you guys.
It's all the-
I'm cold. Anyway, let's go over this. It's a very small chapter, but. Lifespan and development, and all the key things about this chapter, lifespan and development. Is that you have to remember the age groups. And what happens within the age group itself. So people change, people change physically and psychologically throughout their lifetimes. EMTs must actually be able to incorporate the knowledge of each stage into patient assessment and management. So key thing about this is, with adults, heart rate is usually 60 to 100, awake heart rate range per minute. Okay, adolescence is 60 to 100 also. School age child that is a 6 to 11 years of age, 75 to 118. Toddler, preschoolers are 80 to 120, toddlers are 98 to 140, infants 100 to 180, and neonates are 100 to 205. Now, the breathing pattern for adults is 12 to 20, with adolescents, the same thing, 12 to 20. For school age child is 18 to 25, preschoolers 20 to 28, toddlers are 22 to 37, infants is 30 to 53, and neonates are 40 to 60. Now, what's the thing about this is that you have to memorize these numbers. Because if I tell you, well, we have a patient that his heart rate is 80, what's the first thing you need to ask him? What's the age of the patient? Because it might be normal for an adult, but not normal for someone like a neonate. So you have to worry about that. Systolic blood pressure for adults is 120 or less, and diastolic is 80 or less. Adolescents is 110 over 130 to 131. In adolescents, the diastolic blood pressure 64 to 83. Preschoolers 102 to 120, and the diastolic is 61 to 80. School age children 97 to 115 is a systolic, and a diastolic would actually be 57 to 76. The one, did I say that right? Okay, what the preschoolers is 89 to 112, and the diastolic for preschoolers is 46 to 72. The toddler itself is 86 to 100, and the diastolic is 42 to 63. Infants is 72 to 104, and the diastolic is 37 to 56. And neonates is basically 67 to 84, and the diastolic is 35 to 53. Oh, damn it. Neonates and infants, a neonate is from birth to 1 month of age. And this is breaking it down. An infant is 1 month of age to 1 year of age. So from birth to 1 month is a neonate. From 1 month to 1 year is an infant. And during this period, child undergoes rapid growth and development. So they have to gain weight and gain size. Okay. 12-month old, and there's specifically the things that we look for also. Vital signs, respiratory rate is 40 to 60 at birth, decreasing to 30 to 40 minutes per minute. Tidal volume is 6 to 8 milliliters per kilogram. Heart rate is 140 to 160 per minute at birth, and decreasing to 100 to 160 in minutes. Systolic blood pressure averages about 70 millimeters of mercury, and the temperature is 98 98 to 100 degrees. Vital signs, respiratory rate, a 1 year old is 20 to 30. Tidal volume is 10 to 15. Heart rate is 120. Systolic blood pressure is 90, and temperature is 98 to 100. Physiological changes, average birth weight on neonates and infants. The head accounts for about 25% of the body and weight. Birth weight drops 5 to 10% in the first 2 weeks. Thereafter, the weight continues to increase. Initial diet is breast milk and formula. Primary physiological, primarily nose breathers until 4 weeks of age. Airway is easily obstructed, and there are fewer alveoli in the lungs tissue, and it's very fragile. And the chest wall is so soft and with weak accessory muscles. So they're abdominal breathers. Neonates to infants, fatigue can actually occur easily from respiratory distress. So they're going through respiratory distress, they're going to be very weak and groggy, I guess. You have an increased respirations can actually lead to dehydration. Now, why would increased respirations lead to dehydrations on an infant?
Use a lot of energy, they don't have like a lot of.
Dehydration, it's water. Have you ever done this? If you want to find out somebody's alive, you put a mirror under their, they breathe out water, so. Now don't do that because but the immune system is immature. Immunizations are important. Infants are several important reflexes. Extremity movement should be symmetrical. In other words, both arms and then both legs, or all four at the same time. They have an ability to localize pain. Posterior fontanelle closes in 3 months. Anterior fontanelle closes between 9 and 18 months, and examine the fontanelles for assessment of hydration. In other words, if it's all fluffed out, they have too much fluid. If it's sunken in, they're lacking fluid, the fontanelles. You remember the fontanelles, right? La mollera. I remember the first time they ever told me, se le cayó la mollera al niño. And I'm on the floor looking for a mollera, not knowing what the hell a mollera is. And they're looking at me like, what the hell is wrong with this guy? It's like, se le cayó la mollera, la ando buscando. Pues no se la cayó aquí. Ya checó en la casa. Anyway, neonates and infants, physiological changes, 2 months, there's a 2-month milestone. At 2 months, you track objects with the eyes. They focus on objects 8 to 12 inches away. They recognize familiar faces. They display primary emotions and facial expressions. They recognize familiar sounds and voices, and they move in response to stimuli. At 6 months, they actually sit upright. They make up one syllable, ma, mu, da, di. Support upper body when actually on stomach. They grasp and shake the toys, and they follow moving objects with their eyes. And they recognize familiar objects in this distance. At 12 months, they sit up, they sit without assistance and walk with help. They follow own name. They crawl and creep on hands and knees. They put objects into containers. They poke objects with fingers, and they respond to simple requests of no. And they say mama or dada. Now, neonates and infants, psychosocial. Parents must meet the infant's physical, emotional, and psychological needs for healthy development. Infants do not like to be separated from their caregivers, and infants communicate through crying. So they're hungry, they're crying. When they poop, they're crying. And they're angry, they're crying. Can actually detect and respond to parents and emotions. Preschoolers, a toddler that is 1 to 3 years of age. A preschooler is basically 3 to 6 years of age. Vital signs for toddlers, heart rate is 98 to 140. Respiratory rate is 23 to 37. Systolic blood pressure is 86 to 106. And temperature is 98.6 to 99.6. Heart rate is 80 to 120 in preschoolers. Respiratory rate is 20 to 28. Systolic blood pressure is 89 to 112. And the temperature is 98.6 to 99.6. Physiological changes, you have an increase in body mass with decrease in body fat. So they start stretching out. Primary teeth have actually emerged, increased number of alveoli in the lungs, loss of passive immunity, but active immunity actually develops through exposure to pathogens. So they're getting exposed to diseases, and brain and motor skills develop quickly. Physiological changes for 3-year milestone. Walk alone or begin to run, pull or carry several toys when walking, climb up and down furniture and stairs with minimal support, scribble or play with crayons, find hidden objects and sort objects by shape and color. At 5 years of age, they stand on 1 foot for more than 10 seconds, hop, jump, swing, climb, and do somersaults, dress and undress without assistance, count to 10 and more objects, and trace and draw pictures. Psychosocial changes, the language develops, development of separation anxiety at about 18 months. Playtime helps with social skills, speak at the child's level, and allow him to actually touch equipment if necessary, like your stethoscope, your blood pressure cuff, or whatever. Okay. School-age children, a child between 6 to 12 years of age. Vital signs, heart rate 75 to 118, respiratory rate is 18 to 25. Systolic blood pressure is 97 to 115, and temperature is 98.6. Physiological changes, bones increase in density and grow large. Primary teeth have replaced permanent teeth. Ability to read and write, and nocturnal enuresis may actually continue after the age of 10. So what's nocturnal enuresis?
Nocturnal enuresis.
Bedwetting. They might actually be bedwetting after 10 years of age.
They may be what?
Bedwetting, peeing when they're asleep. And the psychosocial changes, friendships are important. For school-age children, problem-solving skills develop, self-concept, self-esteem, and morals develop. You have an increasing understanding of pain, illness, injury, and death. Age 12 to 18, adolescents, you have a heart rate of 60 to 100. Respiratory rate of 12 to 20, systolic blood pressure 110 to 131, and temperature is 98.6. Physiological changes, 2 or 3 year growth spurt. Girls finish growing by the age of 16, while boys actually by the age of 18. Puberty and reproductive maturity develop. Psychosocial changes can occur, result in family conflict, believe that they are the focus of others' attention, and have a feeling of invulnerability. Desire to actually be treated as adults, but legally cannot make medical decisions, and privacy is important for them. Physiological changes, the experimentation with alternate identities. Understand there are actually consequences for actions, may engage in self-destructive behavior. Depression and suicide increases, concern with body image, and may actually engage in sexual behavior. Adult, 20 to 40, which is early adult, heart rate is 70, respiratory rate is 12 to 20, blood pressure is 12 to 80, and temperature is 89, 98.6. Physiological changes, optimum function, increase of body systems, physical peak between 19 to 26, and accidents are the leading cause of death. Psychosocial, increased responsibility and independence, may actually marry and begin families and begin careers with high levels of job stress. Middle adulthood, 41 to 60, you have vital signs, heart rate is 70, respiratory rate is 12 to 20, blood pressure is 12 to 80. Temperature is 98.6, physiological changes, some decline in body systems and concern with chronic disease. Weight gain may occur, vision changes, women undergo menopause in their late 40s to 50s. Physiological changes, problems seen more as challenges than threats. More developed coping skills, aware time limits, focus on others rather than themselves, and transition in parenting. Ages, now late adulthood, 61 and older, vital signs depends on the underlying physical heart condition. Physiological changes, maximum lifespan is 120 years of age. Maximum lifespan is 120 years of age. Of course, you're gonna be in dialysis, bedridden and whatsoever, but
Basically look like you're already dead.
yeah, basically. Okay. Life expectancy varies with year of birth, increased in disease increase. Cardiovascular system changes, increase in the myocardial workload. The brain becomes smaller and more neuron loss. There may be memory problems and disruption of sleep cycle. You have reaction time shows. And respiratory system changes, diminishes ability to actually cough, lung capacity and gas exchange. Physiological changes, diminish in smell, taste, hearing, and vision, diminished pain perception, and kinesthetic sense. They're very prone to falls, like our president. Problems with hydration and nutrition, changes in ability to communicate, and health status varies widely. Physiosocial may actually be satisfied with outcome of life, or regrets can actually lead to depression. Feelings of isolation may actually occur. Financial difficulties may occur, and you have a decrease in independence can actually affect feelings of well-being. That's it. Questions? I'm mature.
Like to go over the test.
Do you have did you all bring your test?
I emailed it to you. I took it off.
Oh, yeah. I tell you what, let's go over the test on Friday.
Okay.
That way we can just, I have it right here, but. I hope I turned this off.